Bem-vindos ao grande round do Hospital de Clínicas, em colaboração com a Faculdade de Medicina da Universidade Federal do Rio Grande do Sul. Hoje estaremos abordando o tema Ética em tempos de Covid, sob uma perspectiva internacional. Esse encontro será conduzido em língua inglesa e, em sequência, eu estarei fazendo a conversão da linguagem. Today, the HCPA Grand Round will focus on global ethical dilemmas after COVID-19. A significant number of patients affected by COVID-19 will eventually require a special care intensive care unit, which represents a major challenge for most hospitals around the world. Eventually, the number of patients exceeds the available number of ICU beds, creating an ethical dilemma. In a few minutes, all of you will participate in a cooperative effort provided by 2 international guests and 3 local professionals, presenting their ideas on how we should face this new reality. Now I will invite Dr. Gilberto Friedman, professor of our Department of Internal Medicine, to present our international guests and our local team. The meeting will include 2 short oral presentations with the international guests, followed by an open discussion session. Please, Dr. Friedman, you can go ahead. Dr. Friedman, you have to open your microphone, okay? And then, okay, Gilberto, go ahead.
Bom dia. Bom dia, professor James Fleck, que coordena o grande round. Bom dia, professor José Geraldo, que coordena o grupo de ensino do Hospital de Clínicas. Bom dia, professora Leia Fialco, que é a chefe do Serviço de Medicina Intensiva. Professor José Gondim, chefe do Serviço de Bioética. Bom dia a todos os alunos, professores, profissionais do nosso hospital e todos aqueles que nos assistem pela internet. Professor Maurizio Secconi, Professor Ian Bacher. Hi, Maurizio. Hi, Ian. I will first introduce you in Portuguese, and then immediately after you start the presentations. You have 10 minutes to present ethics in times of COVID. Just after your presentations, we will start the debate in a talk show style, almost informal, along with Professor Leia and Professor Godin. We are going to ask you a few questions. So first, Professor Maurício Secconi, ele é chefe do Departamento de Anestesia e Terapia Intensiva do Humanitas Research Hospital. Ele é o presidente eleito da Sociedade Europeia de Medicina em Cuidados Intensivos para o biênio 2020-2021, e ele é o atual presidente da Divisão de Assuntos Científicos da Sociedade Europeia. O professor Ian Bacher é professor adjunto de medicina do Columbia College of Physicians and Surgeons, professor associado de medicina na New York University, professor titular na Universidade Erasmus em Rotterdam, na Holanda. Também é professor visitante na Universidade Católica do Chile, em Santiago, e ainda é professor da Universidade Técnica de Delft, também na Holanda, e é o atual vice-presidente da seção de dinâmica cardiovascular da Sociedade Europeia de Cuidados Intensivos. So, Maurizio, we know each other for a few years, and our meetings in Congress and via WhatsApp, have been always a pleasure. And Ian, I know you for exactly 28 years. Long time, my friend, long time. So, Maurizio, you are the first to present. You were in the first great epicenter of the pandemic. I don't consider China a big epicenter. And you spent the whole time in April and March warning us and advising us about everything that was to come in other countries, like New York. And yeah, you were in the biggest epicenter in the Americas, New York. So we are very, very excited to hear from you what you think about ethics in times of COVID. And thank you very much to be with us today. So, Mauricio, you can start.
Thank you, Gilberto, and thank you also to all your colleagues and your hospital, your university for inviting me. It's a great pleasure also to be here with longtime friends like yourself and Jan. So I will give my presentation. Just let me know if you see my screen. Can you see my PowerPoint? Yeah?
Yes, we can see.
Okay, perfect. When Gilberto asked me about focusing on ethics at the time of COVID is interesting, because the first thing that came to my mind was was the concept about this overwhelming number of patients that comes to system that everywhere they have some kind of limited capacity. But then thinking a little bit more, actually, I was starting to think about at the beginning of all the story and how our story started, and probably thinking that this has been indeed a very challenging time, because it has completely disrupted all our way of working. And it was not just about number of beds, but a lot of things, even in the way that we were working with colleagues, and how really we had to react to this, and made me realize really how we are unprepared really for we were unprepared for something of this magnitude. So I will quickly go just to some slide, which is just a little bit of memory, and then I think we can discuss more actually during the second part. But certainly for us, the big wake-up call and the big nightmare starts on the 20th of February. This is when a patient in his 30s was admitted to an intensive care unit in a district general hospital, and he was positive for coronavirus despite not having any risk criteria for being tested. Indeed, the intensivist had to force the local protocol. Up to that moment, we thought that we didn't have any problems in Italy. I remember 4 days before, I was in Orlando, the Society of Critical Care Medicine. Many of you were there. And we were talking to each other, thinking, oh, what's happening in Wuhan, in China. Now we're tracking the cases around the world. The reality is we all knew that this was something that could happen to us, but I had the perception that no one of us thought this can really happen fast and quickly and in a violent way. Certainly that's not what I thought for myself. But 4 days later, I remember I was in the living due of Marco Maggiorini, who is also a friend from physiology of the European Society in Intensive Care in Switzerland. And I started to receive text messages from other colleagues of the intensive care network in Lombardy saying, look, we have a problem, there is being a secondary transmission. That was enough to trigger an emergency meeting, which I think among the many things that with retrospect we could have done better at a political level or at the hospital's level with more time to prepare. Probably that single meeting done within 24 hours of just one secondary transmission, I suspect that's what saved us from collapse, because in that meeting we realized we could have a problem, and indeed the problem would become, as the numbers are telling us, much bigger than what anyone would have thought there. And indeed, when I got the text message, I remember actually not even going to the dinner and jumping to a train without a train ticket to come back to my hospital, so that the day after we started to prepare. And it was interesting because numbers were not enough to say that this was an overwhelming problem, but we realized if something would have happened like in Wuhan, we just had to put the plans in action that we didn't put before. In terms of, so that first reflection for me was also, what is ethics? It's not just about patient, it's also how, what's your responsibility to disseminate information. I can tell you, in my career as an intensivist, I've never seen so many news about a disease as with COVID-19. I've never seen so many drugs being thrown at patients without evidence. I've never seen so many people becoming experts of everything. So I think there was also a concept about ethics of information, and I felt that from Lombardy we had the duty, even if that was only one cluster, but as Gilberto was saying, was the first cluster outside of China, to communicate to the rest of the world that if we didn't have the time to prepare, we had the moral obligation to share everything that we had, even if the data was not perfect. And really, we decided to send this message, which maybe some of you have seen, went around the world thanks to Joseph Keseshoglu. It was an important thing, sending out a letter from the president of ESIC, and I was speaking with Joseph pretty much every day. Remember, at that moment, there was no other place that was really profoundly affected like Milan. So people could have said, maybe this is just another cluster and nothing will happen. So we did decide to send this message out. And in retrospect, I'm very proud that we did that as a society. What was that the things that we shared? Again, many of these things are also ethical principles about how to prepare your team. For me, my memories are always that when I was going to sleep in the evening on the first days, my biggest worry was always, how do I increase capacity now the numbers of patients are flowing? But importantly, I'm the head of the department. I want to protect my teams as much as possible. And I can tell you, at the very beginning, it was very difficult to find material, to find, personal protective equipment. And I'm very grateful, actually, that my hospital listened to me and they put all the requests that I had in place in there. And increasing in capacity, of course, has been the biggest dilemma for everyone, because an intensive care bed is not just an empty bed with a ventilator. It's a group of people, it's a team of people with multidisciplinary skills, with skills that are really needed to use those machines well. And the biggest trade-off that we had with such a big number of patients that we have was really, how can we increase our capacity maintaining a level of quality that is acceptable? Because it's not possible really to believe, and I would be very interested to hear your experience from Brazil. But certainly my experience is that when you double your capacity, you're not running as normal if you're doubling your capacity within 6 weeks. You're suddenly bringing people that have never worked in the intensive care before, or they've not worked for a while in the intensive care. You're diluting skills. The quality of what you do is certainly different, and that's something very important to communicate to your team. I remember I was doing meetings, video meetings at least once a week, and using a lot of email communication to try to tell to my team is, look, what we are doing is unprecedented. Quality now is saving an extra life, but of course it's also difficult to work this way. And the duty that I thought that I had really was, how do I transmit these values to my team and at the same time trying to protect my team as much as possible. I did find that simulation and training were instrumental in the first days. They really allowed us to immerse ourselves into a scenario that then became actually worse than the reality became really worse than the scenario. But those days that we spent really training and try to help each other, to protect each other, were really key. And indeed, in my hospital at least, the number of healthcare workers that became infected was actually lower than the people becoming infected in the community. So I'm finishing soon, because then otherwise we spend too much time here. Really, during those days, there were a lot of debates about, should we put cutoffs about who to admit to the intensive care or who not to admit to the intensive care. I have to say, I was slightly against these mandatory cutoffs because I think it is the role of a good intensivist always to decide who would benefit from intensive care. And so the goal was not for me to provide intensive care to whoever was becoming sick that could get it you, but really was trying to do as best as possible the job to identify who would really benefit from intensive care. I wouldn't say that it has been easy, and I can tell you that some parts of Lombardy, like Bergamo, have been profoundly affected, that I don't know how much we've been able to succeed to do that really just by increasing capacity. But certainly an important thing that was in my practice really to increase this capacity was also trying to find out also properly goals of care. And I have the feeling that one of the most important things that I put in place in my hospital with my team was to put in place a critical care outreach team in which I put two of my most senior clinicians. They were assessing with the emergency department all sick patients coming through the department, and within the first hours deciding very early who would benefit from intensive care early on. So we didn't like to be called during codes. We wanted to predict if somebody would deteriorate, would benefit only from an escalation just to non-invasive ventilation or to invasive mechanical ventilation. And with that, I have to say that even the numbers are telling us we had a mortality that probably is a bit lower compared to the average. Our mortality for the invasive mechanical ventilation was around 20%, and for non-invasive mechanical ventilation much lower than that. Of course, people that didn't come to the intensive care, many of those people died, but we always decided that we would not decide based on the fact that we are in a pandemic, but based on what we think is right for the patient in that moment. So in a way, we decided probably to compromise a bit on quality, but to try to make a very thorough assessment for that individual patient on what will we give to that patient in a moment of normality. So the trade-off for us between probably quality and quantity is being a little bit towards quality. And I saw that, for instance, with hand hygiene standards that came down a little bit in my unit, some cross-infections that I didn't see for a while, and now that the situation is much better, I definitely see that we are working in a much better way. And the last reflection that I have is, I have to say, for me, the biggest difficulty was not managing this large number of patients or making the decisions that we've been trained to make. What I can tell you has been profoundly difficult for myself, for my team, has been all the restrictive visiting policies that we have. Making a connection just over the phone or over an iPad with families was not easy. And I can tell you, I've seen many times my team crying, and we, because we were the last hand really holding hands with patients dying, and and sometimes people die maybe after 30 days in the intensive care and they couldn't see their loved ones. The loved ones could not be at the bedside. I have to say that for me is still something that I struggle a little bit to come to terms, and I find that we have put in place a lot of preparation, a lot of capacity. The community tracking of cases is working better now in Italy. I have the feeling we've not come to a good solution on how to handle family visiting times and so on, in case we will get a second wave of COVID. So these are my reflections, but I look forward to hear the ones from Ian and then to talk more together. Thank you.
Thank you very much. Yeah.
Jan, we are looking forward to hear your presentation. Okay, it's getting now.
Yeah, can you see the slide?
Yes, we can see.
Okay, very good. Well, thank you very much for the invitation. It's a real honor to present some of my thoughts about the COVID-19 pandemic, and I will talk a little bit more about the specific differences between the US and the other country I work in with. Let's say the biggest difference with the US, the Netherlands. And so I keep it a little bit general because Mauricio did a great job in reflecting on what happened on the actual unit and in the context of treating the patients. I will focus a little bit more on the general context of the ethics of in general and the ethics during a pandemic. Well, the general basic principles, I think everybody knows these principles. That's first, do no harm. The second is respect autonomy of the patient. And the third is do justice. And the problem is that ethics is not like physiology. So we can agree on general principles. I think hardly anyone would disagree with respecting the autonomy of the patient. But ethics is not like physiology. It doesn't follow general rules that ultimately dictate the result. And so ethics is basically a consensus of society, not of ethicists. And then we have the interplay with religion that makes it even more difficult because, like for instance, in the US, there is a very vocal and large community of religious people. But if you look at the 350 million people that live in the US, they're not the majority. And so religion in this context can make things even more difficult. And then, of course, what's ethical in one country may be totally unethical in another. Like, for instance, if you compare the US versus the Netherlands, the US has, in general, no problem with the death penalty, whereas euthanasia is seen as totally unethical. Whereas in the Netherlands, the death penalty is totally unethical. And we think that euthanasia is ethically sound. So if we go by the general principles, the first one, do no harm. Well, we have to remember, and that's something that really surprises the nurses, residents, and fellows when I round in the US, is that if there is no benefit that you can think of, then by definition, ICU treatment in and of itself represents harm in an ethical way. And of course, especially in pandemics, when a lot of patients come, this is something that you have to remember. And harm is only allowed if the benefit outweighs the harm. Now, by definition, you cannot treat a patient in the ICU without doing harm. You have to use a ventilator, you have infusions, so you invade the body in the context of treating the disease, and that's great because the let's say expected benefit is much bigger than having a needle or a line inside a vein or a tube inside your trachea. The US perspective is, however, completely different because it's the principle is that when a patient is alert, and so the patient can decide for him or herself, then there is no question that the physician must follow that person's directions, even if the ultimate outcome, death, is not the result that the physician or even the hospital desires or even intends. And so basically, if you translate it into simple language, the patient is in charge. And when the patient is not in charge because he's sedated, for instance, comes in a terrible state of dyspnea and cannot communicate, you have to sedate and intubate. From that point on, of course, the surrogate decision maker is the one who decides. And the challenge always is, at least for me, is what if the surrogate doesn't act in the best interest of the patient? And that's, as Mauricio alluded to, that was especially difficult in the COVID area context, because the family was not there. You could not sit in a room and discuss. You were on a phone, and if you were lucky, you were on a Zoom conference. You could at least see them. But in the majority of cases, we were just on a phone, and it was very difficult to get, let's say, a grasp of what was really driving the family members in their requests for the patient. The other thing is do justice, and the principle in COVID-19 or in any pandemic is that justice, the context of justice, changes from the individual patient to society. I will come back to that later. So do justice in principle implies that if you do justice, you basically are also doing harm. So if justice means that you save the 25-year-old but not the 90-year-old, then basically you're harming the 90-year-old in order to treat the 25-year-old. So in these pandemic or in these constraints of resources, the do justice principle is still there, but the context changes from the patient to society. And this is also in conflict with US principles, because in the US, where it came from, it's the autonomy of the patient, so the patient can refuse care. And in the US, that has been basically translated in that, okay, if I can refuse care, then I also can demand care. And when we accept that the patient can demand care, then the society, the pressure of the society can be like, okay, then you have to do something, or your family has to do something, because I can't live or couldn't live with myself if we didn't try everything. That's a discussion I had in almost every patient that died in the ICU. In the majority of patients, it was like you have to do everything, even if it doesn't make any sense. I consulted Art Kaplan, that's our ethicist at NYU and one of the nation's most vocal ethicists in the US. And I was talking about whether we should use an anti-IL-6 inhibitor in a patient where I thought it didn't make any sense. He said, I would offer every treatment and have the family decide. And so you can see that there is a huge difference between the ethical, let's say, concept regarding care, of course, healthcare in the US. And so in the pandemic, the focus of the system changes from the patient to society. So due to justice gets a completely different context. It's not the patient, it's the society. And so what we usually do when we have, let's say, enough resources available, then you treat the patients on a first come, first served basis. That's something that you should not do in a pandemic, and that's something that happened in many countries. Because if you do first come, first serve in limited availability of, for instance, ventilators, then you violate the do justice principle that has changed from the individual to society. If you talk about this, it's reasonably simple and everybody understands, but of course, many problems persist, even if you agree on all these principles. Are you saving lives? So are you saving individual patients, or are you saving life years? So how do you incorporate age in decisions like that when you, for instance, have no ventilators anymore? Is there a priority of non-COVID over COVID patients? What's the status of healthcare workers? In the Netherlands, for instance, healthcare workers come first if they are, let's say, healthcare workers in the COVID context, so in the ICU or emergency room, and if when they got infected, for instance, PPE was limited available. What about the duration of care? Is it you're admitted to the ICU and we will treat you as long as it takes? Like, for instance, we had a 50-plus-year-old on ECMO for 80 days. Is there a limit to how long you keep those patients in the ICU and on the ventilator? And then at the end of the day, even when you agree on all of these principles, what are the limits of error? What is the limit of you make a mistake in predicting the chances of survival? How is that, let's say, agreed upon in society? And as you know, the litigation in the US is huge, and you can be, let's say, litigated for almost everything. There was limited litigation in COVID, so it didn't drive a lot, but in general, healthcare litigation is, of course, very important in the US, and the limits of error are extremely small if you, for instance, compare it to the Netherlands. And so that's an ultimate discussion nobody ever had in my context, but I think is very important. So I leave it here. Thank you very much.
Thank you very much, Jan. So we have two moderators. So I think, Leia, would you start?
Leia, you have to turn on your microphone.
Okay. If Leia is having some connection problem, maybe Goldie? Okay, Leia. You're okay.
Thank you very much for the invitation and the opportunity to discuss with you, Professor Jan and Mauricio, the issues regarding the COVID pandemic. We, as Professor Jan presented a very embodied information regarding the ethical issues, and we have some questions our fellows provided us, which are very much similar, some of the aspects that were presented here. But maybe I would just like to try to convey Mauricio's point regarding the very early and overcome position. How does that differ from what Jan has pointed out in the United States as it pertains to the difficulty, first of all, to allocation of patients, decisions making. So you need to build several other places with different care intensities regarding other fellows. Could you comment on that?
So if I understand the question is to compare a little bit the experiences between myself and Jan. I mean, it's difficult because I didn't work in the US, but I worked 14 years in the UK. And so I like very much what Jan was saying. It is ethics, you know, where you work, it's a little bit of a consensus of a society. I completely agree. But it's also when you compare studies and you want to bring them to patients, you know, studies give you an average, but then that individual patient needs individualization of therapy. So I certainly find, you know, when I moved back to Italy, the culture of the people and the system is different from the UK. But it does not mean that in the UK I didn't have some situations that were very similar to Italy and vice versa. And, you know, in some individual for which maybe you would make decisions that are completely different than others. And that's why I think, personally, not having the families at the bedside has been so difficult. It's been so difficult because you have to interpret and to forecast in a way what would have been the reaction of that patient without knowing so much of that patient. Maybe sometime what would be the reaction of the family just by, you know, just by speaking with them over the phone. So I have to say everything that Jan was saying, I could relate to myself. And I find myself that, you know, when you talk about ethics, it's that's true in medicine overall, I would say, but particularly when there are ethical issues, maybe sometimes it's more important the questions that you ask rather than the statements that you make. And you know, when you start to ask these questions, and importantly to discuss with colleagues, you know, we have a rule in my unit that, you know, important life, end of life decisions, and even decisions of not admitting to the intensive care, we decide, it's always been like that, but I made it kind of mandatory because more people were doing intensive care. They always had to be discussed at least between two senior consultants. So we always said, when there is something that you feel it's a strong decision, always discuss with two people. And if you have a disagreement, take a little bit more time, and then we bring a third person to speak about it. I don't know, Ian, what you think. But
Mauricio, you have mentioned cutoffs, and I didn't realize exactly what cutoffs means. And you have a clear definition. What are your cutoffs?
no, and I didn't use at all cutoffs in my unit. But what I was saying is that within 2 weeks of the pandemic, we had already had a document from the Italian Society of Anesthesia and Intensive Care. There was kind of saying if you have limited capacity, then you should choose between, you know, patients with the highest probability of probably of surviving or benefit, etc. I personally find that a little bit uncomfortable in the sense that I really wanted to do the things that I was doing before. And the first decision for an intensivist is not which type of ventilator you're going to use, is would this patient benefit from a ventilator? That's the very first question. It's not what type of ventilator, if it's a good ventilator, if it's a, you know, I had to use anesthetic machines. They're not ICU ventilators. But that's because the question in that moment for me was, would this patient benefit from ventilation? If the answer is yes, I would use an anesthetic machine. I think you guys have done the same. I think most people have done the same. I didn't reach, and I was lucky enough that we had a moment where we went very close, but we didn't go there. I didn't reach the stage to do things that I didn't know if they would have been ethical or not. We trained on simulation. We even have the videos of preparing, but we decided not to release the videos. So we even prepared for a situation in which we had to use a ventilator on 2 patients. And we create a full protocol to match compliance, to see how not to cause harm and etc. But we didn't release that video because we thought we want to be ready, but we don't want to give the impression that that is good intensive care, you know. So that's why when you refer to the cutoffs, I think it's not good intensive care if you have a document that is telling you who to admit and who not to admit. You cannot put the individual you know, choice that you have in front of this patient together with the cultural background, the society background, the resources that you have, the skills that you have with your team. That's the experience, that is the job that we love, and it takes years to get. You know, you cannot get that with 2 days of reading a document, I find.
Godin, you have a question?
Thank you very much for your presentations, Professor Mauricio, Professor Ian. The topics presented were very important and insightful for me. I would like to ask 3 questions. The first involving more details about end-of-life situations, especially decisions about palliative care and terminality of the patients in ICU. The second, if possible, about the healthcare situation in Sweden, which has restricted access to many patients of healthcare institutions, including basic and palliative care. And finally, what thoughts you, in your opinions, on the aspects of medical ethics and bioethics could be incorporated into healthcare practice now and after COVID? Thank you very much.
Your microphone is on, Ian. You have to start.
Well, those are great elements. With the fact that family could not be present, well, we allowed family, if we were sure the patient would die, the family was allowed 10 minutes. And when I asked, why not 15? Of course, nobody had the answer. And I said, I mean, that doesn't make any sense. 10 minutes, why 15 or 30 minutes? If they wear a mask and a face shield, why can't they be there be 30 minutes? But it was 10 minutes. That's a severe limitations in end-of-life care. The other thing, of course, is the fact that the whole decision process was by telephone. You called the family, and then you had to come to an agreement. Of course, the end-of-life care in the most severe conditions was much simpler than in other cases, because we didn't do any end-of-life care in a patient that was awake and able to make a conversation like you sometimes have in patients on ECMO. They're awake, they can be awake, or patients on LVAD devices or RVAD devices. That's much more challenging. That's something we didn't have. But it's, as Mauricio said, it was more the context than the actual process, because we're, I think, very experienced in end-of-life care. I always say the intensivist should be the best end-of-life care doctor in the world. I hardly ever consult the palliative care team. And so, yeah, that's something that we can do very good. But the context was much more difficult. I didn't exactly understand what you meant with the situation in Sweden.
Because Sweden restricted a lot the access of healthcare facilities there.
The access, yeah. Well, I don't think that's good. And I fully agree with Mauricio. We have very well-trained doctors. And the basic question is not predicting the benefit of, let's say, being admitted to the hospital when you have COVID-19. That should not be a decision that is made by administrators or hospitals or even government. I think that's the basic thing that doctors should do. And what they did in the Netherlands, because it was, to be honest, not very different in the Netherlands. But what happened is that the primary physician of the patient went to the patient, discussed the situation, discussed the what it would take to go to the hospital, and even if they required intensive care, and then have a meaningful discussion with the patient. And in the majority of cases, patients in nursing homes and in LTACs or long-term care facilities, those patients said, "Not for me. Please leave me here and let me die in a nursing home. I don't want to go to the hospital." And that's a completely different thing. That's not limiting access, but having a meaningful discussion on whether the patient thinks that he is willing to go through the process of harm, because that's what intensive care treatment is. It's a process of harm. Whether the patient was willing to go through that process in order to benefit from the possible outcome. And so I think that makes sense. I completely disagree that you should limit access to healthcare for anyone, because one of the ethical principles is that everybody is the same. And if you have these, let's say, limited access to healthcare, very rapidly you get like, okay, well, the mentally disabled shouldn't go to a hospital. The elderly, the comorbidities, the patient on a ventilator in the nursing home should not go. That's not okay. It should be the principle of, will there be any benefit? And then when you decide that there will be benefit, but there are no resources, then different elements of ethics come into place, but not a general restriction. And I'm not okay with that at all. And then what could we learn from it? Well, that's, I think, from my practice in the Netherlands, I think they have, let's say, put more attention to age, because they found that so many elderly people didn't even want to go to the hospital. So that's something that I think, and that's also what they integrated in the new guidelines, that age should be an element of your, let's say, assessment of the patient. I think what we should learn in the United States from this is so big that it will be almost impossible to incorporate, because the system was totally driven by patients. And so the, let's say, the shortage of resources was driven by culture. not because there were no ventilators or because there were no doctors or nurses to take care of these patients, but it was totally driven by the fact that every patient needed to come to the hospital and preferably die in an ICU. That was in many cases a big cause for the shortages. So pre-hospital triage, it was done, absolutely. In LTACs, of course, patients, and as you know, in New Jersey, you can be brain dead and still on a ventilator. And of course, they wouldn't send a patient like that to the hospital. But in the majority of cases, they were admitted. And the two extremes I have admitted was a 93-year-old with a lot of comorbidities and a patient who was on the waiting list for a hospice. And both were admitted to the ICU and put on a ventilator. And that's not okay. And so there is so much that we have to learn in the US, but that totally is, let's say, at odds with the society and with the cultural aspect of I demand healthcare because I pay for healthcare and stuff like that.
I would like to make another question. Dr. Jan has mentioned the surrogate decision making, and probably this is very frequent, very common. How do you feel? Do you feel confident with the surrogate decision making?
No, that's a huge problem. That's a huge problem. It's something I discuss on a regular basis with nurses and residents and fellows to give them perspective. In the Netherlands, when I was a resident in training for internal medicine, we instituted a new rule in the hospital that every patient, whatever the age, had to come when requiring admission, had to come with a documentation of an end of life or goals of care discussion. And so from the early phase of my training, I have had discussions with young patients, old patients, on what are the goals of care when you're admitted to the hospital. And I have never, ever seen a patient who said to me, well, if I go to a nursing home unconscious for the rest of my life with a PEG and a trach on a ventilator, that's great, let's do it. And so whenever I had these discussions with family members who demanded the patient with let's say a cerebral bleed because of the anticoagulation, never to wake up again, to be transferred to a nursing home with a PEG and a trach on a ventilator, I always said, I'm very sorry, but I don't think you're here representing the interest of the patient, unless you can document or really give me a good explanation why you think your father would be happy to be in a nursing home unconscious on a ventilator. So no, one of the problems in the American system is that we give as doctors options and the family decides. And my stand from the very early beginning, when I had patient discussions with family members, I first gave my impression. And so I said, I'm very sorry, but your father is going to die and I'm not going to resuscitate. I hope you agree. Instead of, your father is very sick, do you want me to resuscitate? I think that's wrong. And especially in these telephone conversations, and this was very difficult. So I always started with my professional opinion in these. To help basically the surrogates to make a decision that was, let's say, in the interest of the patient.
If I can make a comment, I completely agree. And both Ian and I, we worked in different countries. But I remember when I was a trainee in the UK, one of my mentors told me, it's really wrong to go and ask a family, what do you want? Think about how long it took you to learn these skills and to understand that the treatment that you do may have some benefits. There is the uncertainty. Human beings, it's so difficult to think about uncertainty. We like to think about something that it happens or it doesn't happen, but the reality is not like that. There is a degree of uncertainty, and I think it's our experience, our skills to do that. So no, I completely agree with Ian. I think I really don't like when doctors go and say, what do you want? I think you need to explain the situation, give the context, give your preferred option, say, you know, what you do. And I often say, look, if this was my father, this is what I would do. And then, of course, you know, it changes country on country and patients on patients and family on family, the way you communicate and the way that the decision is accepted. I find that, you know, probably in the majority of the time, if you're clear with your assessment and you know, and your choice, but you are the one that needs to make the choice, it's too much of a burden for families to make those choices. It's our job to make those choices. I would say in the majority of these cases, they are accepted. I'm not saying always, because we all had difficult family conversations and difficult times where the family does not accept your decision. But I think that's the problem. It's not when they don't know how to make the decision, is when they do not accept your decision despite the explanation. I think for me, that's the difficult, you know, that's the difficult family conversation. It's not when they want something you don't want. I really think it's the wrong approach if you go and you say, what do you want? You know, they are not paid and they didn't study medicine to do intensive care.
I'd like to make a comment on how we are dealing with the communication. We have some colleagues that are in charge of making the communication among families and healthcare providers and their loved one who is in COVID. In a sense that is the healthcare provider, the intensivist is the bedside. It passes the information so we can keep the dialogue. So this is has shown to be very a good way to communicate and to interact with the health professional. I'm not sure whether you use this approach. We have many people around the city who are dealing with doing the same process. In addition, we have built some little, I don't have mine, but some big photo that will show who the healthcare provider is, because of the masks, you cannot see who is taking care of you. So that gives a little more of humanity during the care. Just a comment regarding how we're dealing with this. In addition, we have, because we need too many people, about 101 beds, we're having the collaboration of the university professors and some of the people from the hospital, which have taken tutorials to provide this information, which has been very successful.
I don't know if I understand perfectly the system that you have, but I understand that you have somebody in the team that is in charge of communicating basically with the family. I guess we all find similar solutions to this problem. What I would say is that if you have someone that is in charge of communication, it brings one thing that is very important for families, which is continuity of communication. If every day they speak with someone different, they find it very stressful. Also because it's very difficult for, I would say, the 9 of us here on this screen, if we have to communicate the same thing, probably we would do it in a slightly different way. And so, of course, you cannot do it for a month in a row, but at least maybe a week. You always have the same person that updates about the progress and so on. No, we also use that approach. Initially, we had some senior consultants doing that. When the number of patients was too much, because they would have just spent the day speaking on the phone, we also separated and say, you will take care of this communication with this family for these days. And I agree, it's very useful, because then they find the continuity of care in the voice of the people that they hear every day.
I would like to address one issue. The time is running, so I would like to cover another subject. I don't know in Europe, but I know that in US and here in Brazil, we have big confusion with information and misinformation about treatments. simply primary care. I don't want to talk about hydroxychloroquine, but I want to talk about ethics on this. We are academics, we are professors, we have our role in the society. But it was a confusion. And I think not we, but the society did harm to ourselves with this confusion. I would like to have your comments. For instance, compassionate use of drugs in the beginning, but then after the studies, everything continues the same, or even worse, using ivermectin with plus zinc, plus, I don't know. So from an ethical point of view, I would like to hear from you.
I was the same, I think, everywhere. I can tell you I did spend the majority of the first weeks convincing. I didn't have to convince my team because we built a culture together of first do not harm and try to do the simple things well. So, but try to resist to the cause, because that was the problem. You didn't see the families, but then the family saw on the news that this doctor from this city has found this magic treatment that is saving everyone. And then they were asking you, is my father on this treatment? And you have to tell them no. And can he have it? And you have to say no. And you have to explain that. That was adding another layer of stress on the communication. So I would say the fake news or the bad communication that we had, that's what I was saying in the beginning of my talk, I've never seen so many drugs used on, something like this. And I am sure that if COVID-19 was something that affected 20 patients, not millions of patients, we would have not seen this. We would have not seen this. It's just that everyone was, and I'm not sure there is any, I wouldn't say there is a malignant intent in the doctors that have tried to do that, but it was certainly bad practice and bad way of communicating to use all of this. I think certainly one other thing that made me realize is that is not only that we were not prepared at an organizational, clinical, public health level for something like this, we were not prepared at a research level, not as well as we should have done actually, to do research in this, to try the drugs. That's why I think really, we have to praise the efforts like REMAP-CAP or the recovery trial, or the Brazilian study on hydroxychloroquine. What you guys have done is amazing, to be able to randomize so many patients during a pandemic, to deliver the results that they can inform practice at the bedside, because otherwise all the rest is noise. I remember speaking with colleagues, and they use some immunomodulators and they say it works on 70% of the patients. And I say, why do you say that? Because I had a 30% mortality. And you say, how can you prove the causality? I have a 20% mortality in my ICU and I didn't use any of these drugs. So we really made so much confusion between association and causality during this pandemic, which it is a bit of a worry. And that's why I was saying before, as human beings, we are not used to think about uncertainty. We think in a very linear way. We think in numbers and in black and white or yes and no. We struggle a little bit with uncertainty. We struggle a little bit with mathematics when they become exponential. That's why people still don't understand that wearing a face mask is a good thing with a virus that replicates in more than one. No, but I think, Gilberto, we had the same experience around the world.
Yeah, I think you have to add one thing, and that's very typical for the American population, is that they're willing to accept a harm or zero benefit if it offers an opportunity. So I've had many discussions with family members. Even some of the family members were willing to come and deliver anti-IL-6 antibodies to the entrance of the hospital because they were not allowed. So pay for it themselves so that we could infuse it into a patient. Because we had a discussion that I said, well, the patient won't benefit. We're 3 weeks into COVID. at this time, anti-IL-6 will do nothing. And they said, well, we pay it ourselves and we bring it. And I said, but it won't help. And the answer I always got, you cannot deny me hope. And so if society is like, okay, I will do everything as long as it creates hope, even if because of the treatment my father will die, then you come in an extremely difficult area where you have no arguments as a researcher anymore. Because when a family member says, you cannot deny me hope, my answer was, no, of course not. I cannot deny you hope. But we don't treat your family member on the basis of hope. We have evidence or we have physiological principles or whatever, but not hope. It's not like throw everything in and let's hope for the best. That's not a medical treatment. But a lot of family members were willing to basically do harm just because they thought it would offer them hope.
Unfortunately, we are getting close to the end of the meeting, but if anyone wants to make a final comment, please go ahead.
I would like to make a comment. How do you think you can mitigate what we have been dealing with in Italy, in the United States, regarding the possibility of a second wave? Some may say it's a bumpy one wave, but maybe we'll be starting to discuss that. How can you deal and mitigate the feelings that you had and things that happen over time? We're not there.
I think there the United States is a great example on how not to do it. Because what you see in Europe, what has been done in Europe, and I think especially the data from Italy are very instructive, because they had a huge surge and were able to bring it down to almost let's say 0 cases by doing stuff that makes sense and at the end of the day worked. And basically what the United States is showing, if you don't do that, then you don't get over even you don't get the second wave, you remain in your first wave. And so I think the examples the European countries set, like Italy, like for instance Germany, they show that you can do it. And then of course you can discuss on how much burden do you want to accept. But the United States has clearly showed that if you don't do that, then you don't even get out of your first wave.
You know, with some colleagues in the weeks of the peak, we were reflecting, because we were seeing so many patients building up from the clusters, and we wanted some cities to be locked down very early. And in those cities, I think in retrospect, maybe we've lost a few days there. They could have been locked down earlier. But that's, again, it's a problem I find overall with human psychology, because if you have a problem and then the problem is very big, everyone realizes, okay, this is something we have to sort out and we now have to slow it down. And indeed, we were able even to slow down even in Italy. I think the situation is much more under control now. However, I remember that, during the days that Italy put the full lockdown of the country, I know there was a lot of discussions, do they do it, do they don't do it? Remember, Italy was not in a fantastic economical situation before that. And let's say that you do it before you have a huge problem and nothing happens. No one will tell you, you've been great, you've done fantastic, you spare a pandemic. A lot of people will criticize you to say you acted on panic and you killed the economy. And unfortunately, I think we have enough information now to realize that this is real and this can bring waves of pandemic everywhere. We can still have a society that works almost normally with some rules about face masks and social distancing. But now that we don't have a problem as big as before, now there are some groups of people that say you're limiting my freedom by asking me to wear a mask. And So unfortunately, history, it's very easily forgotten. But what Ian was saying is, is right. We have the tools to bring down the pandemic. And until we don't have a specific therapy, we have to learn that we have to live with the virus. In the intensive care, we can manage a significant number of these patients. We cannot manage too many patients, and I think it would be a failure of the system to believe that the solution to this is increasing ICU beds. The solution of this is to have an acceptable number of transmission that doesn't kill your economy, doesn't prevent kids to go to school, it doesn't prevent young people to get a job and carry on with life. But this is a battle that I think we win in the community with the responsibility of individual citizens. And without panic, we can have a reasonably normal life. It's not so bad to wear this.
Okay, we are getting to the end. And now I would like to thank all the participants. I would like to special thank Dr. Gilberto Friedman, who is a professor of our internal medicine department, to whom I would like to address a special thank you for the organization of this excellent meeting. Dr. José Roberto Goldin, Chief of Bioethics Section of HCBA, Dr. Leah Fialkov, Chief of the Intensive Care Unit Section in HCBA, Dr. Jan Becker, Professor of Medicine at Columbia College of Physicians and Surgeons, New York, USA, and Erasmus University at Rotterdam, Netherlands, and Dr. Mauricio Ciccone, Chief of the Department of Anesthesiology and Intensive Care at Humanitas Research Hospital in Milan. Thank you to everybody. It was an excellent meeting. You are a wonderful person and excellent professionals. Thank you very much. Until a new opportunity. Hello.
Thank you very much.
Thank you very much for the invitation. I really enjoyed. Bye-bye.
Bye-bye.
Very good. Thank you.
Thank you. Bye-bye.